Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello, and welcome everyone. My name is Renee Garrett, and I am your Speech Therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Ashley Muñoz López is employed by one of the largest hospital systems in the country. She is in leadership and receives a salary. Additionally, she is employed by a university as an adjunct lecturer and receives a stipend. Ashley receives an honorarium from Speech Therapy PD for her podcast guest appearance. Her non-financial disclosure is that she is on the Adult Swallow Committee for the 2024 ASHA Convention. No relevant non-financial relationships exist. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. I am the host of Brainstorms, Functional Neuro Rehab for SLPs, and I host other webinars on speech therapy, PD, where I do receive financial compensation. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Ashley Muñoz López, MBA, MS, CCC-SLP, BCS-S. Ashley is a board-certified clinician with experience in direct patient care, project management, service line development, and leadership. She worked as a speech-language pathologist for over a decade and has experience working with children and adults in various practice pathways. She has substantial experience working with patients with acquired brain injury, respiratory compromise, and dysphagia. Ashley has been published in the ASHA Leader and Aerodigestive Health, as well as the perspectives of the ASHA Special Interest Groups. She received the Distinguished Early Career Professional, or ECP, certificate in 2018 and graduated from ASHA's Leadership Development Program, LDP, in 2019. She is a current member of the Hispanic Caucus for ASHA and a previous board member. She's been a guest speaker for several universities and has presented at the local, state, and national levels, including multidisciplinary presentations with nursing organizations. Most recently, she was invited to be a speaker at ASHA's Upper Airway online conference. In 2020, Ashley began her term as a site visitor for the Council on Academic Accreditation, or CAA. Ashley provided dedicated service to ASHA's Special Interest Group 13 as a professional development member from 2021 to 2023 and the CE Content Manager. Currently, she's serving on the Adult Swallowing Committee for the ASHA 2024 Convention. Outside of her duties in the clinical realm, Ashley empowers diverse members of the healthcare workforce and was the 2022 co-chair and 2023 chair for the Hispanic Latinx Alliance for the Houston Methodist System. She currently serves as a part-time lecturer for the University of Texas, Rio Grande Valley, a Hispanic Serving Institution, or HSI. Welcome, Ashley. Thanks for being here.
Thank you so much for having me, Renee. I'm excited to speak with you all today.
Yeah, I'm too. We have some more things in common. I read through your bio quite a while ago, and so reading through it tonight, I'm also an ASHA LDP grad from 2023. So that's was a pretty cool thing to be a part of.
Absolutely. I loved it.
Yeah, I learned a lot. Matter of fact, our cohort, well, our team inside the cohort is trying to get together quarterly to kind of maintain those relationships. So it's really cool to see somebody else who had that experience and understands that it wasn't just about learning about leadership, but making more network connections, which is always a really cool thing to do.
Absolutely.
So in thinking about, I know what I was going to say, also adjunct lecturer for 2 universities myself. Matter of fact, I was talking about disorders of consciousness in my TBI class this morning. So it's kind of funny that it fell on the date that I was covering it without me realizing or being aware of it. That's how the schedule fell. So I feel like I'm semi up to date.
Yeah, well, I like the cosmic world and how it brings us all together. So that's really cool.
Yeah, for sure. So let's kind of jump in and talk about disorders of consciousness and maybe give sort of I know it's hard to define, but give like a more broad definition of what disorders of consciousness are.
Yeah, so disorders of consciousness is a severe acquired brain injury. It is a medical condition that inhibits consciousness. Some define disorders of consciousness or as any change from complete self-awareness to inhibited or absent self-awareness or arousal. So there's loss of consciousness and coma, vegetative state, which is what we call minimally conscious state, and so on. And so we have sort of a spectrum of degrees of awareness that some individuals go through very quickly, and then we have some individuals that it may take years for them to travel through the phases of consciousness.
Yeah, one of the things that we talked about this morning were in fact tying it to the severe brain injury. And so I think an important distinction for the students, at least, was to learn that brain injury from trauma is one piece of it, like car accidents, falls, head injuries in sports, that kind of thing. But then also, you can have a severe brain injury from a disease or illness, such as a heart attack that stops your heart and makes you have to be resuscitated. So those are kind of the things that we kind of touched on this morning. Anything about that you want to add or kind of maybe speak to?
Yeah, that's an interesting topic, and one that I want to point out too, because we have traumatic brain injuries and we have acquired brain injuries similar to an anoxic brain injury, as you described. And typically what we're seeing in the research is those that have non-traumatic brain injuries tend to receive better care than patients who obtain a traumatic brain injury. And I mean, there's a whole plethora of reasons, but that's really important to think about it when you're looking at a chart review and you're forming a hypothesis before you go in to see that patient, is really try to remove that bias that patients who sustain a traumatic brain injury tend to have worse outcomes. And research is saying that that's not the case.
Yeah, that's a good point. And I think that distinction of that 28 days or longer marker too for the whole the prognosis for patients and how much ongoing therapy they're going to need afterwards. Because I think, going back to the definitions, like if we define coma, vegetative state, and oh my goodness, why am I drawing a blank? Minimally conscious, I had to think of so minimally conscious is what they're calling the vegetative state now. Is that correct?
Yeah, so that's the new term that we are moving towards, minimally conscious.
Yeah. And then, so kind of talk us through what that looks like as far as those three levels of where the patient is at when we think about what their sensation may be like as far as their brain's ability to process things like voice and understand or hear, because we hear that about patients in comas, right? That especially people who are in ICU and intubated, that they can hear people talking, and that sometimes that's the thing that sort of helps them, or they feel like that's the thing that gets them through their illness.
Yes. So if you have had the fortunate or unfortunate opportunity to go under with anesthesia, most people do report, hey, I could hear people talking before I could see, before I could move. And so you have to imagine everything with when our brain is waking up, that it's the same pattern for everybody, no matter the injury or situation. It's the timing. Some people may be stuck in minimally conscious state. Some people may be stuck in a different phase. What we typically move through very quickly, the Glasgow coma scale will rate people very quickly, and it'll say, oh, they've moved through these stages quickly. This is important to know that just with DOC, it's a slower rate, but vestigial reflexes and things of that sort recover first, right? So you've heard that term before, like lizard brain, our more primal part of our brain that is responsive to things like fight or flight. So that's the part of the brain that is activated when we're coming to consciousness. And when we wake, if you want to pair it to the Rancho's Los Amigos scale, we're at like Rancho 3, where that's minimally conscious positive or minus. And that's where we typically think patients are appropriate for rehab, right? Like this patient is appropriate to go to inpatient rehab, but that's not. We can see patients who are unconscious with their eyes closed and see them for meaningful, skilled therapy that is multimodal and multidisciplinary. And so it's kind of, for the therapist, is just rethinking how we address these things with patients, and how we as therapists can think outside of our treatment box and meet that patient where they are.
Yeah, no, and I think that's a great point, because what I was talking to the students about, and what I've talked to my former students about, is when you go into the room, you need to make sure that you are still treating this patient with dignity and respect, introducing yourself, saying why you're there, what you're going to do. Never put your hands on a patient that you haven't told your name and why you're there. Because if that was your loved one and you watched that happen, I would probably lose my mind. Because I mean, when my dad was sick, we saw people come in and out of the room who never said a word. And I can imagine how startling that would be if you're in this state where you can't respond, but you can hear what's going on around you, or you can feel someone touching you and you don't know what they're doing or who they are.
Absolutely. And I think that I'm really passionate about this subject, and I've read books and articles and things to kind of help me better understand and kind of tailor my treatment approach. I'm going to make a plug for a book that, if somebody is really passionate about this, is really understanding that whole process of I'm awake, I am in here, and I have no control of what I'm doing. There's a book by Martin Pistorius called Ghost Boy. It is a biography of his journey through disorders of consciousness. So he spent about 10 years in a facility before he was able to really functionally communicate and get the care that he needed to be able to progress. It's a wonderfully written book. And so his particular brain injury was acquired, and it was a form of meningitis. So it wasn't traumatic, and he was young when it happened. His parents did not want to withdraw care. And so he talks about how in the beginning stages, he was maybe only awake for 30 seconds, and then it would fleet, and then it would progress to 5 minutes, and then it would go away. And then he was like, then it started lasting longer, and it was ebbs and flows, and it gradually improved in the length of time until he was finally able to show somebody that he was in there, which, brings a really startling statistic by Caroline Schnaker and colleagues that 41% of people who are deemed in the vegetative state in a nursing home are actually more awake. They're not in this persistent vegetative state, and they're awake. And so Martin Pistorius' story takes place overseas, but there is a case in Arkansas. His name is Terry Wallace. He spent 19 years in a nursing home before he woke up. And he was a traumatic brain injury. So these people are waking up decade after their injuries, and they're telling the stories of what happened to them. So if you're really interested in that, I mean, look into those stories.
Well, and I think from a medical perspective too, if you are someone who works in acute care or who even previously, like I previously worked in acute care, I haven't been there for about 2 years now. I really liked Every Deep Drawn Breath by Dr. Wes Ely, who has done a lot with trying to change the landscape of how we sedate and keep sedated ICU patients in particular with chronic or long journeys for their illness. And he's got some pretty good stories, but has also done a lot of work for having this information online and having support for these patients who have had these experiences like that. So that's another really good. It was very eye-opening. My husband, who's not medical at all, actually read it, and he was like, "This is fascinating."
That book is on my list. It was supposed to be part of my summer reading list, but I didn't get to it. But I have it, and it's going to be part of my fall reading list. So you're one of many people who have recommended that book. So
yeah, it's pretty incredible, and his website has really good stuff. I actually reached out early on when I started the podcast, but he might be too famous for me, so I don't know. I might knock on that door again. But, I think just getting the diagnosis accurate is one of the things I think is really challenging for the medical team too, because a lot of times, like you mentioned, they sometimes overdiagnose and think these patients are more, for lack of a better word, like a layman's term, more out of it than they really truly are. And I think that is a huge problem. And there is a lot of research about that's very helpful, like the study that you mentioned. But then again, when we're going back and we're looking at those guidelines for predicting health outcomes, we know that minimally conscious state tends to fare better. So, so we've been told, but then again, like you said, there's research now that says that this vegetative state I think I'm saying that right. I'm getting ahead of myself. I'm reading a question and thinking what I was going to say at the same time. So if you rescue me, I'm fine with that. But thinking about the patients who the outcomes that are predicted being more minimally vegetative state, that they think that they tend to have better outcomes. You mentioned something about the research with that and maybe not necessarily being accurate.
A book that I absolutely think everybody should read, especially if you're like me, who kind of likes the origins of things and likes to know about the history. And I think that comes from my father being a history professor, but Rights Come to Mind by Dr. Joseph Fins really talks to you about the federal part of it, the stories. This research is embedded in this book, and he is the one he's a bioethics professor. He's an amazing speaker if you ever have an opportunity to hear him. But what he talks about is that with the traumatic brain injury versus an anoxic brain injury, it's trauma, right? And so oftentimes these patients have physical changes to their body, broken bones, bruises, bleeding, stitches, right? So when you look at the patient, you can tell that they are hurt. But when you look at a patient who has an anoxic brain injury, they're unblemished, right? They're in the same state that you saw them in. So there's that visual change that's objective, right?
Mhm.
Like you can see that. And then when a patient sustains a traumatic brain injury and the medical team feels like it could go one way or the other, there's a federal mandate that a hospital has to notify organ preservation organizations that there may be a pending donor. And that's a federal mandate, right? And so that's just kind of subconscious, unconscious pressure on a family to make the decision to compassionately withdraw care.
Yeah.
And we know that patients with traumatic brain injury, the leading cause of death is compassionate withdrawal of care in the ICU.
Yeah.
And so there's, physicians saying, look at your loved one. He's sustained, compound fractures in a car accident or, X, Y, and Z, depending on the mechanism of injury. We don't know where it'll go. Right now, he's in a chemically induced coma, right? And that's another thing. Oh, they're chemically inducing this coma to reduce the swelling of the brain. It's not necessarily the body putting the person in a coma. Now, when they wean those drugs, they may stay in a coma, but they also may wake up. So that's also a thing that, family members who don't have the medical knowledge, training, background, or experience with other family members, when they hear coma instead of medically induced coma, they go to, a different part of that. And so really understanding the differences and the reasoning behind the medically induced coma, and then trying to wean the sedation and seeing where they come. And it's important that, speech therapists, neuropsychologists, physical therapists, occupational therapists, music therapists, whichever therapist that is doing the intervention for a minimally conscious state really has to talk with the medical team about what sedatives are being used, when they are, before they really start doing that serial testing to determine where they are on the conscious continuum.
Yeah, and I'll tell you, I've seen it happen where they went to withdraw care and the person woke up. I've seen it happen. The first time it happened, I was actually the first time I knew of it happening, my patient was in inpatient rehab at that point, but she told the story herself, and her daughter came in from out of town and told the story. And it was like the patient was, I've never forgotten her out of the hundreds or thousands of people I've treated, because she said, I could hear things that were going on, and I could hear them talking about LifeNet, which is what the hospital systems here use. And she said, I don't know, I felt them pull the tube out and I just woke up. And I was like, what? It was like the craziest thing I've ever heard. But she was like, I guess I was still meant to be here, so I didn't die. And I was like, okay, let's get to work, sister. We got things to do. And then the other time I saw it was actually in ICU, and it was the same thing. They turned off the sedation, and it was actually a traumatic brain injured patient who'd been in a pretty serious accident. And when they turned off the sedation, started weaning it down, he started arousing. And by the time they had it had only been a few hours, he was awake, sitting up in bed, talking to his family. And, like you said, a few hours before that, they were making this decision about whether or not to withdraw care, which was crazy. So
yeah, it happens. It happens
yeah.
a lot more than we think it does. And so if you're working in a trauma 1, trauma 2 hospital, you're probably encountering these patients, or maybe you're not, because you're not getting consulted on them, right? Because the medical team has already kind of made that decision that the patient's prognosis is not to a level that is meaningful or that can obtain a quality of life. And so the family has made those decisions without serial testing, maybe minimal neuroimaging, and, and I mean, maybe the patient has a living will and that's what they wanted, right? I can't pass judgment on those situations. But what I can say is advocate to be in those rooms, advocate to understand and create a team of disorders consciousness evaluation, because there is meaningful recovery. I have seen it myself, and I was astonished. I was like, this person, had such a crazy event and then left our hospital coherently talking, decannulated, eating a diet. Like, it was like, wow. And so when you see it, I think too, you're like, I love this. This is where I want to be. At least that's how it was for me. So yeah.
Yeah, it is pretty amazing. And the fact that, just speaking to like a chart review, how many times have you ever done a chart review and then you go in to see the patient and you're like, well, that's weird because that's not what they look like at the bedside in either a positive or a negative way. I mean, there's been plenty of times where I've read a TBI patient's chart and I've gone in to see the patient and I'm like, well, that's not what I expected. And so we do sort of get that clinician bias. When you've been doing it for a while, you read the chart, you kind of know what to expect, and then you go in and you're like pleasantly unexpected is what you see in the, it can go both ways. But I think the big thing is understanding the risk of, or not the risk, the necessity of, like you said, us being on those teams and having that early voice to say, okay, this is what kind of testing we need to be doing, or what kind of stimulation this person might need in order to help facilitate that vegetative state into something else.
Absolutely. Yeah. You said it perfectly.
Yeah, I really studied for that CCC-S when I got it. It really, so people ask me all the time, they're like, when you got your CCC-S, was it easy? Did you just pay for it? And I'm like, absolutely not. I had a notebook that looked like I was still in grad school that I studied from. It was hard. It was a hard test and it had a lot of information.
Yeah, there's definitely some reverence for the CCC-S. I held the CCC-S previously and I let it go for terrible reasons. I didn't keep up with it. And then when I tried to, I was like, okay, I'll retest it. I'll study again. And I was like, oh my gosh, this is a lot. I'm in a different season of life. And so I chose not to proceed it, but I think it is an amazing certification that really is helpful to your clinical practice.
Oh, I think so too. And I've thought about doing they have a new one where it's the CCC-S, and I can't think of the initial. It's not the trainer, it's a different one where it's a little bit more intense. But because I'm not working in the trauma spaces anymore, yeah, I'm like you, I'm like in a different season. I don't know that I could have the capacity to keep all that information in for a test at this point. It kind of makes me itchy thinking about it.
But I mean, everybody who's pursuing it or who has it, kudos to them.
That's right.
The certified brain injury specialist certification is really, it's worth it, really. And it does demonstrate your expertise and your clinical knowledge.
Yeah, I agree with you. It was a lot of information. And even now it's, I try to make sure that I include, because I can include dysphagia CEUs, but I try to include things like this for disorders of consciousness or other things that are a little less mainstream, so that I can try to make sure I'm keeping up with my knowledge base too, because we never know where we're going to land next as far as jobs go. Things happen, people move and all that kind of stuff. Mm-hmm. But when, let's talk a little bit more like long-term, and then I want to get into your co-authored article. Thinking about, again, the severe trauma brain injury versus the severe, like a hypoxic or anoxic event. We saw a lot of hypoxic and anoxic events happen during COVID. And a lot of those patients are continuing to deal with more long-term disabilities, just like our patients who have had heart attacks or strokes that were brain bleeds and things like that. What are some things people can look at as far as what they need to plan for or be thinking about as a clinician for more of that long-term role that we may have with these patients?
So when you are maybe dealing with a patient who's minimally conscious or in the disorder subconscious continuum, and you're saying, well, where do I take this patient? Where do I go from here? Really always base it on function, right? Like patient will reach for objects, and then always in your goal in preparation for accessing AAC, in preparation for self-feeding, right? So, your goal may be very simplistic in what you want the patient to do or respond with, but always include in preparation for, so that the medical team understands what you're doing. The payer sources can see that pathway that you're walking with the patient, and go from there, right? So whether you're a physical therapist who wants the patient to kick the ball in preparation for extending gait, whether you're an occupational therapist who, you want the patient to reach for something in preparation of ADLs, a speech therapist, you want the patient to bring a cup to mouth in preparation for eating. What are the longer term goals? And then as the patient, quote unquote, wakes, becomes alert, and sustains a level of arousal or wakefulness for 90 minutes, right? Then that's when you can have the more conventional goals, right? Patient will utilize X, Y, and Z, or patient will participate in functional language tasks and things of that sort. But just like with any brain injury, whether it be acquired or traumatic, you may have dysarthrias present themselves. You may have dysphagia that presents itself. You may have aphasia, right? So these patients have very complex brain injuries. So as they progress through the Rancho scale, you may see things pop up from a speech therapy standpoint that you weren't really anticipating, but you're like, oh, now that you're talking, I see that you have dysarthria. Oh, now that you're talking, I can see you have word finding difficulties. Or now that you don't have continuous oral suction, or I see that you're having difficulty managing your saliva. Let's work on secretion management so that you can start eating and drinking. All of those things will start to present itself like much more what you're used to in treating patients in inpatient rehab or even in the acute side.
Yeah, and it's interesting. I ran through the first class I taught for this TBI cohort. I did a neuroanatomy review, and I could almost feel the students like, oh, like the collective, oh. But I tried to explain to them, because I think, when you're a graduate student, well, really, even undergrad, it's sort of hard to understand how the course content is applicable clinically, because we're trying to learn this course content and we're like, why do I need to know this subcortical tract, and why do I need to know this about the brainstem, and why do I need to know about the pons in the midbrain and all these other structures? And so I said to them kind of midway through, when I could see that they were all like deer in the headlights, like I said, you have to understand your brain is interconnected. So even if the part of your brain that's damaged, or the part that you're seeing where things should be occurring isn't the damaged part, something on the way in or out is damaged that's preventing this patient from being able to complete this task. And once I said it that way, I think they were all like, oh, so that's why I need to know, like, the corticospinal tract and all this other, information that we went over. And I say all that to say, I agree with you 100%. We wind up seeing these patients with what we thought was just going to be, like, I say just, like this is such a simple thing, a cognitive communication disorder, which is not a simple thing, that may have components of aphasia, may have components of an attention disorder that maybe they didn't have before. And so the dysphagia piece, this is a perfect way to move into that, because we know that, again, the brain is interconnected in the way that it's working together. We may see that dysphagia impairment, whether it's from the injury itself, the length of the vegetative state that occurred, the hypoxic event itself, or all combination of all those things. So kind of talk us through that and maybe move into like the inspiration for the paper that you co-authored.
Yeah. So it's funny because I started my career loving TBI. I did a clinical fellowship at a neuro rehab. Loved neuro, went to trauma one, was on the trauma team, loved it, loved COG, was like, give it to me any day. I'll these are the people that I love to treat and work with.
Mm-hmm.
And then I moved into LTAC and started doing a lot of disuse atrophy dysphagia, right? Just like the domains of a dysphagia was the domain of whatever they had. And then I don't want to say stumbled upon, I feel disrespectful to the disorders of consciousness population, but I became aware of them. And then I was like, oh my gosh, this is TBI and dysphagia. This is like the most interesting population that I have ever had an opportunity to work with. And that also was so underserved, under-acknowledged. And it needed to be, shouted from the rooftops that we as speech therapists can do something about this, and we can intervene sooner rather than later. There's so much research about early intervention in the ICU, early mobility in the ICU from the PT and OT standpoint, but that we can do that too in speech therapists. Like, we're mobilizing their brain, we're mobilizing the structures of swallow and speech. Like, that's mobility as well. It's just in a different plateau, right? So it's a different plane. And so when I have taken a great amount of time in forming a great collaborative and strategic relationship with the attendings in the ICU at my former job. And when I said, hey, is there something I can do with this patient? I had enough of a relationship and built trust with them to say, well, what can you do? What is been in the ICU for, over a month, and family wants everything done. So I started doing research. I had, this is what I can do. I stumbled upon, the CRSR, and I started getting people in my department interested and excited about it. And we started working with this patient, and we started just seeing what he could do. We were already doing inline speaking valves on the ventilator. And so I had a conversation with the attending and asked if we could try inline speaking valve on this patient. And he said, well, this patient, was not going to speak to you. He's not going to, he has no meaningful expression. And so what do you plan on doing? What is your goal or your means to an end? And I told him, I said, I just want to restore sensation and airflow to the upper airway. I want to see what will happen with this patient. It will stimulate him, and let's see where it takes us. And so when we did that, right, when we deflated the cuff and secretions came up, he coughed, right, which is a reflex.
Huge. Yeah.
He started smacking his mouth because he probably tasted the mucus. I don't know. I can assume, right? It was a noxious internal stimulation. And then his actual cough is an internal stimulation that we could not replicate outside of him, right? And so he did that. And the doctor was like, he had a reflex. And it was like, yeah, but we're sustaining that reflex because we have the cuff inflated. Like, we're managing his secretions. He has no reason, his body has no reason to elicit a cough, much less produce one. And so just by doing that simple thing, even the physician and the medical team started thinking about treatment differently. And as this patient progressed, we had conversations of, well, he's never going to be decannulated. And I would say, well, why not? If he's managing his secretions and he's, on parasol trach collar. Why wouldn't he? And so they were like, well, because his conscious state. And so we kept working on him. We kept moving it. And he started tracking. He started swallowing on command with ice chip trials. We kind of used just a culmination of different therapy approaches, right? The McNeil dysphagia therapy protocol that, you swallow things that are safe to work on to things that are not safe, and get a variety of textures and viscosities within that diet. Research tells us that we can do a modified and fees on disorders of consciousness patients. We don't have to wait. So that's another means of early intervention and mobility. And so how are they managing their secretions? Are they sensing things? Are they, sticking a scope in your nose is highly noxious stimulation. What are you going to do? Of course, we obtained consent from the patient's caregivers or family members before we did that. But I mean, that's some pretty deep stimulation. What's that patient going to do? Are their eyes going to awaken? Are they going to move? Are we going to automatically see a hand raised to their face because they want to move it away from them? Like, those are all things that we can do. Of course, we want to talk the patient through it. Like you said, Renee, like, hey, my name's Ashley. I want to do a swallow test to see if we can start getting you to eat and drink. I have this scope. Here, look at it. It's right in front of you. It has a light with a camera at the end. I'm going to put it through your nose, and we're going to see how you're responding to small bits of ice chips. We can do the Langmore ice chip protocol with you, and we can see where you're going secretion-wise and how we can progress you. And, the speaking valves, I've talked with Dr. King from Passimere, and we've talked about it of like being asleep and being minimally conscious are two different things.
Right. Yeah.
PMV says do not wear during sleep.
Right.
Not when you're minimally conscious. And so I was like, oh my gosh. And, obviously, when you put the PMV on, it restores upper airway. It helps you build a more robust taste and smell sensation, which the DOCS-25, which is a formal assessment of disorders of consciousness, just like the CRSR. But I like the DOCS-25 because it does specifically target smell and taste. And so how you're putting, this patient has a trach, and you don't want to put the PMV to restore that upper airway, to restore those senses. Are you really giving them the most robust treatment? Are you really giving them the best opportunity to show you what they can do? And the answer is no, if you're not putting the PMV on this patient. And so me and my colleague, Mary Louise, wrote an article about it because we were encountering some of the best minds in disorders of consciousness. And, some of them were saying, well, we capped the patient, but it's only for like 30 seconds. And some were telling us, we really haven't done research because, these trach lores, right, of like tall tales from the trachs of like, no, this is not the thing. And it's like, no, we've got to right the wrong. We've got to educate everybody as much as we can and shout it from the rooftops. So that was really the driving force for our article, was you can use speaking valves with patients with disorders of consciousness because there is a stark contrast between sleep and minimally conscious, and then how it can progress towards decannulation and how that helps a patient's quality of life, progression, just accessibility to the community. And, there's no reason to have a trach if you can maintain an airway and maintain your secretions. And so I know that there is a lot of medical teams out there that are just really conservative, and that's okay. And I think in some circumstances that I will never know the complexities of, that it is an appropriate recommendation to send a patient home with a tracheostomy tube. But as therapists, we have to give them the opportunity to not have that happen to them. And we know that it reduces the cost of medical care once they discharge from their rehab facility or from the hospital. And we know that it actually can help reduce infection if they no longer have a tracheostomy. It also reduces caregiver burden, right, of having to maintain a tracheostomy tube. So tracheostomy tubes are a tremendous tool that help save lives, but they don't need to be with them forever.
Yeah. And one of the things I would say to this population too, when, they were appropriate enough to do a fees or modified barium, often I would get from the family, or it was usually family, but sometimes caregiver that, may not be related to the patient, would be, well, the doctor came in and said, this is kind of for nothing, that they don't expect he's going to really do anything. And I'd say, let's prove them wrong. Let's prove them wrong. Let's just do it. Roll the dice, right?
Yes. Prove them wrong, because the patient has the right to have a meaningful recovery. They have the right to access medical care. And we may be small, but we have mighty voices as therapists. And so we've got to keep fighting the good fight and giving those patients the opportunity to have appropriate care.
Yeah, for sure. And I think that, going back to mentioning LTAC, we had an LTAC floor in our inpatient rehab facility, our inpatient rehab hospital. And definitely feel like that was like where to me, those two facilities being in the same hospital was like, I learned more in the first 3 years of my career working in that environment than I probably have collectively since. Because you got such a wide variety of reasons that patients were there, particularly in the LTAC. We had the good fortune of doing both respiratory rounds and wound care rounds with the team, the head wound care nurse and the respiratory therapist, whoever happened to be caring for that unit. And you got to see some of the worst cases. And then you might go back the next time they did respiratory rounds and this patient's sitting up in bed and you're just like, what happened? And then it was a different time, because this was 2010. So it was a little bit different time, and it was a harder sell, I think, being in a smaller space, because I think when you're in a much larger health system and you've got these teams that are treatment teams already in place, like a trach team or the trauma team, we didn't always have that level of, because it wasn't a huge hospital, we didn't have all that stuff in place. And so I think when you have that opportunity, it is really a great opportunity for you to learn, but also to advocate, like you said, for your patients, because some of the treatments for disorders of consciousness involve other medications. And I don't know how well all that's been studied, because there are people, like, for instance, with amantadine, there are people who can't take that. They may have another health condition that is not a barrier. What word am I looking for? A comorbidity that would prevent them from being able to take that medication. So I think, for us to be able to be involved early on and do these things that are so important is really just, it's crucial. And so I really appreciate your work in this realm, and the study is very good. So I thought it was very good.
Thank you. I mean, I think it's kind of an unorthodox way of thinking about it, but when you think about infants in the NICU, right, and they're talking about experience-dependent neuroplasticity, how we have to give them exposure and really just, what's the word? It's just, we have to give them experiences, right? So that's exactly what we should do with patients who are recovering from a severe brain injury. We have to provide them experience-dependent neuroplasticity. We have to give them the experience to react, to respond, to have enriching environments that make their brain turn on and fire in different ways and build alternate pathways. And so we've got to do the same thing. And I've got the term experience dependent neuroplasticity from the pediatric world, right? Like that's a term in pediatrics, specifically in PD dysphagia. And so it's the same thing, right? Like essentially we're rebuilding pathways in a patient who was an adult who had everything and didn't need to mature as an infant in the NICU does. But it's the same theory behind why we need to be in the ICU with them, why they need to have the opportunity to have multidisciplinary intervention.
Yeah, and again, going back to that whole interconnected brain, the frontal lobe's connected to the parietal lobe. We could make a whole little song about it, but it is impactful when you think about it that way. And so one of the students this morning had a great question about what's something, we were looking more at the cognitive realm, but it could be swallowing as well when you're thinking about food selection. If the patient has, is safe to go ahead and have some PO, what are some early on tasks? And so I said, well, now we have the person from food services who comes in with their iPad or tablet or whatever you want to call it, and they take the food order, but the patients get a menu in their room. And so you can actually use something that seems like it's not therapeutic to make it therapeutic. Have them, and we're talking about people who are more moving out of they're more awake. They're able to arouse for periods of time, but they can look at, if they don't have visual impairments, they can look at, find the day of the week. We're looking for lunch. What is served for lunch? What do you think sounds good? I mean, you can do all these different things, and it sounds like, I told the students, it sounds like a bunch of hullabaloo, but it's actually very functional for the patient to be able to start somewhere, identifying a need, identifying a choice. Even if you have to read it for them, give them a forced choice, it's still the same functional task that gets them engaged, gets them. Most people are, that's a pretty universal thing. Most people are pretty motivated by food. That's why it's a primary reinforcer. If you go in and you say, would you like chicken noodle soup or tomato soup? A lot of times people are like they have a very strong opinion about it. I hate chicken noodle soup. I'm never going to pick that. So I would pick tomato.
Yeah, yeah, exactly. Like, especially if you've been in the hospital for long periods of time and you're like, if I have another one of those baked fish plates, like they're so angry that they're so motivated to tell you or show you that they want something differently. Whether, give them a field of two and give them directional eye gaze. Look left if you want this, look right if you want that, or touch my left hand if you want this, touch my right hand if you want this, activate a switch, point to a picture board, right? There's so many different access ways that you can also start teasing out in the ICU or in inpatient rehab of like, what AAC device does this patient need long-term, right? And starting that process, because we know getting a speech generating device takes forever, and the documentation behind it as well is arduous and sometimes repetitive because you have to keep resubmitting to the payer source. But all of those things are valuable things that you can be working towards in any setting that you're in.
Yeah, and I think, going back to, you mentioned the CRRS.
Coma scale revised. No, I'm doing it's colloquially known as the JFK because that's where Dr. Giacchino created the CRSR, but it's no longer the JFK. Dr. Giacchino is no longer at JFK Hospital. He's now at Spalding in Boston. And so we're moving to the CRSR. And so now there's also the CRSR fast. So a lot of the people are like hated the CRSR because it took so long to administer, about 60 minutes. And if you're in acute care, you're like, I can spend 60 minutes, on 5 patients. That's it. That's all I'll get to see. And so they've just created the CRSR fast, which is a hyper-focused assessment that's similar to the CRSR, just abbreviated, and it's serial testing, and it's the same thing, and it's really it's only been researched in the ICU, so they're not saying to use it in inpatient rehab or in other settings, but in the ICU as of right now. But more research will come to show us that, but I was really excited to hear that was already out in the world. And so if you're interested in learning about that, There are training videos on how to do it. There's no certification to administer the CRSR or the CRSR fast. It's, you just have to demonstrate competence and make sure that you are following the guidelines and the protocol in administering.
Yeah. And the other one, say that one again, because I want to put I'm trying to put this in the chat box to kind of help people with.
So there's the DOCS 25, the Disorders of Consciousness Scale 25. And that one's interesting because it was created by a speech therapist. It's Dr. Pappy or Dr. Pope. I don't know how she pronounces her name. It's P-A-P-E, Pape. It may even be Pape. But she created the DOCS 25. And then I am familiar with the CRSR.
Mm-hmm. Yeah. Yeah, I just wanted to put that in the chat because I'm on the East Coast time zone, so I'm on the downward slope of my consciousness right now. And not to make light of this, because I definitely don't want to do that, but it's just definitely a place where there's a lot of research to be done and a lot of spaces that we can put ourselves in for advocacy. What would you suggest is, like, if you are in a smaller, more, like I was in a more rural hospital for a while, for those clinicians who maybe don't feel like they found their voice, or maybe don't feel like they can speak up or advocate, maybe they're a little intimidated by the medical team if they haven't had, like, I had great experiences. I went in and they knew who I was, and sometimes I would get the, oh, good, you're working this weekend, and I was like, what?
No.
I've been saving this for you. And I'm like, please don't. But what would you suggest would be a great way to start with maybe fostering those relationships, or providing an access pathway for us to have a voice?
Yeah. So I will say the first and foremost is everyone is that it's not completely dependent on the therapist. You also have to have willing and open ears that on the other end of the spectrum. So you can be, the most eloquent therapist, you can know everything, but if you have somebody who's not open to hearing your recommendations or thoughts, it's not your fault. So I think first and foremost, I want to say that, but you can't give up. I had the tremendous opportunity and luck and fortune to have a medical team that wanted to know and listen and collaborate with me. But I will say they did test me when I came on. The doctors during roundings would ask me questions like, what do you think this? And very much treated me like a resident. And I had to prove myself when I was requesting orders or when I was suggesting that we get a ENT. They wanted to know why. And if I couldn't articulate the why, they weren't as willing to proceed with that recommendation. And so my ability to articulate the why and provide the critical reasoning and critical thinking, I developed trust in them, and they saw me as a colleague and not a consult. And we did amazing things through COVID with that relationship. And we trusted each other, and we did things together, and we made it out successfully. And it's funny because I remember in COVID, I wore a scrub cap all the time, and we were all gowned up, and all you could see really was our eyes. And as COVID started to clear, the vaccines came out, and it wasn't as intense as it was. I took off my cap, and the doctor was like, Ashley, when did you get gray hair? I was like,
during COVID.
And he was like, are you okay? And I was like, I'm fine. We're good. And he was just like, I just remembered you without gray hair. And I was like, well, here I am. Let's keep going. And so having those conversations, being able to talk to each other as humans and not just as professionals, I think is also a thing as well that you have to develop. And that doesn't happen overnight. If you're a CF or 2 to 3 years out, like maybe you do have the gift of gab. I didn't. And I had to work at it really hard, and I had to boost my own confidence. And, imposter syndrome is real, but as long as you are confident in what you know and you can portray that, you will move mountains for patients. You may not move mountains for the hospital, but for that patient, you've changed their lives.
That's
That's
right.
enough. At least for me, that's enough.
Yeah. Yeah. And another thing I tell people, or students in particular, early career professionals, is go in armed with a couple journal articles, because there's nothing that kind of gives you, I don't want to call it, I said street cred this morning and my students were laughing, but it does. It lets you be seen as valuable, because you're looking at this research that is in our profession, in our field, that people sometimes don't even know exist. We are trying so hard to make sure people know what our role is, but we know what our role is. And if we can, like you said, demonstrate that value and demonstrate the fact that we do know our stuff and we are able to make such a difference for these patients, is just amazing. So go in armed with a research article. One of my students this morning said the pediatrician, she's doing a pediatric rotation right now, and the pediatrician denied ENT consult. And I was like, why? And she's like, I don't know. He said they might grow out of it. I said, get you some journal articles and go back. She was like, well, my supervisor didn't suggest that. I said, well, you can use it as a freebie and just go in with journal articles. Don't tell them who gave you the idea.
Yeah, that's funny. So I'm actually in pediatrics now, change of pace, but yeah, I've heard like, oh, they'll just grow out of it. And it's like, do they grow out of it, or do they learn how to mask it?
Mm-hmm.
And the same thing with adults, right? Like,
Yeah.
they learn to live with the deficit.
Yeah.
And so it's the same no matter how old you are. You need rehab and you need strategies and you need to recover. And so for that student, articles are going to help you, but also just being able to say, but what if they don't?
Right.
Then
Yeah.
what are we setting up this patient for in their future? And I don't know the issue or whatnot. I don't have any basis, but it's pretty universal to be like, but what if it doesn't? And what's going to happen to them long term if we don't fix it now?
Yeah. Or at least try.
Mm-hmm.
Yeah. Give them a chance. Well, Ashley, this was fantastic. I really just appreciate you agreed to do this. And I feel like for both of us, this is such a passion topic. So I felt like it was a really great flow and a great episode. So I appreciate your
If we ever catch
willingness.
each other at ASHA, let's grab a glass of wine and talk about TBIs. That would be great.
Oh yeah, for sure. I'll be there. I'll be there this year. I'm actually presenting on PCS and CTE, so come visit.
Very cool. Congratulations.
Yeah. Thank you. I appreciate you being on here and taking the time out to work with us. So hopefully you have a great rest of your evening. And again, just appreciate you being here.
Well, thank you for the opportunity to share one of my passions.
For sure, for sure. Thank you, and we look forward to seeing you again.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying audio course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use BRAINSTORMS20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.